So next, we'll be hearing about SGLT role from prevention to treatment by Samit Ghosal.
We analyzed the cardiovascular risk using QRIS-3 in patients who do not have established cardiovascular disease. And the high-risk group were the individuals who have type 2 diabetes duration of more than 5 years, males more than 45 years of age, female more than 55 years of age, automatically has a QRIS score of more than 20%. So they have a more than 20% risk of developing heart attack or stroke. So these are the risk factors from the Indian population, because whatever we heard of previously are from the Caucasian population. What about risk stratification for heart failure? Today we have 2 risk scores based on artificial intelligence and modeling, which has been released this year. One by the Israeli group, which is called the Timi-Hadassah risk score. Very simple risk factors. Take a past history of heart failure. Is there an atrial fibrillation or not? Is there a past history of coronary artery disease? Is there a micro or macroalbuminuria? Is the eGFR less than 60? Based on which you have the scoring out there. And any score more than 3 is equal to a very high risk for developing heart failure or hospitalization for heart failure. It's simple to do. But a better validated risk score is the WATCH-DM. I think it's very complicated because the amount of time we have to spend in doing this risk score is practically not possible in a busy clinic. But this is another way of doing it. For microvascular complications, we have this already set with us. We must do a 10-gram Siemens-Winston monofilament testing to look for LOPS, which is loss of protective sensation under the legs or the soles. Annual screening for retinopathy and annual screening for nephropathy should be done with estimation of eGFR as well as urine ACR. Now, from this risk assessment, we have to come and formulate a device or management plan for a patient. Today, it's completely the other way around. First, choose drugs which secures outcome benefits. Then bring in drugs which can reduce and help you in reduction of blood glucose. Like I will tell you, a sulfonylurea, a DPP-4, a glitazone can come in as a second, third, or fourth line drug. They should be used. It's not that they are not indicated. But first, secure outcomes benefit. First, give drugs which is securing outcome benefit as step 1. Step 2, complement with agents which are achieving the A1C target. Step 3, tackle other comorbidities aggressively: systolic blood pressure, quit smoking, lose weight, as well as the lipid management. So from the glucocentric point of view, this is the summary of all the complications that our patients can develop. And if I just manage HbA1c and bring it to target, these are the 4 yellow boxes which we can tick as being covered. 1, prevention of new onset or progressive retinopathy, macroalbuminuria, non-fatal stroke, and all-cause mortality. These are the only 4 complications we can prevent by achieving our A1C target. What about the rest of it? And this is where today we are lucky to have drugs like SGLT2 as well as GLP-1, which can help in reduction of ESRD, renal death, myocardial infarction, cardiovascular death, heart failure, and all-cause mortality. So from prevention to treatment, we are actually treating the tip of the iceberg. We are allowing our patients to develop those complications, and then we are jumping in trying to do something about it. But instead of that, the blue zone is the opportunity zone, where if we can jump in, we can prevent the patients going into the red zone, and we can prevent a lot of complications. So in order to understand SGLT2, which is the molecule I'm supposed to talk about, how does it benefit compared to others? So this is one of the meta-analysis which I did, and it was with all the DPP-4 inhibitors, SGLT2 and GLP-1, with all their outcomes. And you can find with the outcome trials that we had with the SGLT2, there was no macrovascular benefit. There's no reduction of MI or stroke. There was reduction in hospitalization for heart failure. The 3 SGLT2 companies are fighting with each other. Some saying, I'm reducing CV death, I'm better. Some are saying, I'm reducing heart failure, I'm better. I can only choose one of them. I cannot use all the 3 drugs for 3 different indications in the same patient. Remember, the entire benefit is driven by hospitalization for heart failure. So even if there's a reduction in CV death, that is also driven by hospitalization for heart failure. Now, to understand that, we need to understand the cause and effect relationship. We need correlation study, for which, again, I did the Pearson correlation coefficient study, which is just published around a month back, finding out the relationship between hospitalization for heart failure and cardiovascular death. If that is so, then between the 3 drugs, we are looking at sort of a class effect when it comes to the macro and microvascular benefits. And as you can see, our data shows that if you look at the coefficient correlation is more than 80%. Relation between hospitalization for heart failure and cardiovascular death, which proves the point that the entire benefit that we are looking at from the heart point of view is driven by reduction in heart failure or hospitalization for heart failure. Now that has been vindicated, that thought process of ours, because of the DAPA heart failure trial, which recruited patients with both diabetes as well as non-diabetes, and there was a significant reduction in cardiovascular death or hospitalization for heart failure in that cohort. The outlier out here was a CREDENCE trial, the only trial which used the renal endpoint as the primary endpoint and showed significant renal benefits. What we are looking now is stroke benefit with GLP-1, myocardial infarction reduction with GLP-1, heart failure reduction with, and cardiovascular death reduction with SGLT2, and renal benefits with SGLT2. So those other boxes which were empty are slowly getting ticked with these drugs. Now, we need to remember what percentage of our patients will benefit with this drug. And this is a very poor slide. I've just took a snap when Melanie Davis was presenting this at last EASD, and she made a very pertinent point. Whenever we are saying that there are microvascular nephro benefits with an SGLT2, it is only when your eGFR is less than 60, and it's only when your urine ACR is more than 300. You know, identifying a microalbuminuria and rushing into an SGLT2 is not the answer, because there is no benefit in microalbuminuria. It's entirely in macroalbuminuria, as well as when the eGFR is less than 60. So to conclude, this is another data which I have suggested for regulatory authorities. We have number of positive outcome benefit coming out from a lot of drugs. And some of them are statistically significant, but not clinically significant. Look at dulaglutide versus liraglutide data. 350 grams is the weight benefit of lira over dula, which is highly statistically significant. Ladies and gentlemen, is 350 grams a huge weight loss? That statistical significance is telling us to choose A molecule over B? I think his answer is no. So we should always look at two factors. One, what is the absolute risk reduction, based on which, what is the number needed to treat? Is there a persuasive p-value, a p-value less than 0.001, which means there's 1% chance that that thing has happened by chance. And if you put all those things together, clinical plus statistical benefit, there are only 3 benefits coming out with SGLT2 inhibitors. Cardiovascular death with empagliflozin, the cardiorenal benefits with canagliflozin, and worsening of CV death or heart failure with dapagliflozin. These are the only 3 benefits that we find. And that is reflected in the guidelines. I will end this with the latest guideline, which is released this month. And this guideline is an updated guideline for SGLT2, ARNI, as well as many other agents with cardiac amyloidosis. We have empagli, canagliflozin, and dapagliflozin, which can be used in type 2 diabetes with atherosclerotic cardiovascular disease to reduce the risk of heart failure, hospitalization, and death. It's a strong recommendation. So whenever a company comes and says, oh, CV death is only with me, that's wrong. All the 3 can be used when you have an established atherosclerotic cardiovascular disease. In type 2 diabetes, with age more than 50 years and additional risk factors of atherosclerotic cardiovascular disease, which are 3 or more risk factors, or target organ damage, dapagliflozin has the strongest recommendation to reduce the risk of hospitalization for heart failure. Cana has the strongest recommendation with age more than 30 years and macroalbuminuria to reduce hospitalization for heart failure, as well as cardiovascular and cardiorenal death. DAPA can be used in mild to moderate heart failure due to reduced ejection fraction, left ventricular ejection fraction of less than equal to 40, which is called HEPREF, for progression or for risk of hospitalization and cardiovascular mortality. And also it can be used in non-diabetic heart failure patients with an ejection fraction less than 40 to improve symptoms, quality of life, and reduce the risk of hospitalization for heart failure and cardiovascular death. Be a little bit cautious of the last recommendation. That's a conditional recommendation, because the label update is yet to come. But most probably we might see the first molecule from our area entering into the non-diabetic heart failure stage with the help of dapagliflozin. So these are the latest recommendations. Be cautious. Highest risk patients benefit the most. Not all our diabetic patients are highest risk, and hence identifying the highest risk is extremely important. If we do not identify the risk factors, we do not know who is going to benefit with the drug. So we should go stepwise from identifying the risk factors to the management strategy. Thank you very much.
Any questions are welcome.
This typically nephropathy is always considered a microvascular, but CKD is a CVD risk equivalent. So is it time to now call nephropathy as maybe a macro, or just a macrovascular complication?
I agree with you. It's too arbitrary. We should not differentiate complications between micro and macro. Even heart has the microvessels which can get impacted. As a matter of fact, the earliest indicators of screening a patient for complications of retinopathy. The smallest vessels getting affected means you have to look for cardiovascular and renal problems. So this is very arbitrary. And that's why I think it's logical now that they're clubbing it into as a cardio-renal outcomes. So it makes sense.
If no more questions, now
Thank you.
we'll close this session. Thank you, sir.
Thanks to the speakers, Dr. Uday Phadke, Dr. Shailaja Kai, Dr. Samit Ghosal, Dr. Deepi Kadam, Dr. Ranjit Patil.